Hello everyone, I have made this video on posterior semicircular canal BPPV with the intention of sharing a few points on how to diagnose BPPV. BPPV is the most common peripheral vestibular disorder that we encounter in our practice. Usually it manifests as sudden short-lived episodes of vertigo lasting between a few seconds to minutes, and this vertigo is usually provoked by change in head positions such as turning in the bed, bending down to pick up a object, or trying to get something from top of the shelf, and so on. Now I have a video of a patient with left posterior semicircular canal BPPV. You can see that when the patient is put into the head hanging position of left Dix-Hallpike maneuver, what happens is that after a few seconds there is a nystagmus, and this nystagmus has a vertical torsional component. The torsional component of the nystagmus usually beats towards the affected ear, that is the left side in this case. Now, this nystagmus and the symptoms associated with the nystagmus is going to last only for a few seconds. Now, I'm going to share a few things on the nystagmus of BPPV. What are the characteristics of the nystagmus? First thing is, this nystagmus has a latency. Why? Because the otoconial mass that is displaced into the canal, and which actually causes changes in the hydrodynamics of the endolymph when it is moving like a piston, what you call as canalithiasis. So this particular otoconial mass must overcome the resistance of endolymph in the semicircular canal. So this whatever time that is taken for this explains the latency of the nystagmus. Why does the nystagmus last only for a short duration? This is because the endolymph drag and the current ceases when the canalith mass reaches the limit of descent in the canal. What is responsible for the patient having a reversal of nystagmus and the symptoms occurring again on sitting up in the Dix-Hallpike position? This is because the canalith mass moves in the opposite direction in the endolymph, and this is responsible for the recurrence of symptoms when the patient sits up. Why is the nystagmus fatigable? This is because on repeated Dix-Hallpike positioning, the larger otoconial mass disperses into smaller particles, and of course you know that they will have less endolymph drag than the larger otoconial mass. So this is responsible for the fatigability of the nystagmus. And unlike a central nystagmus, this nystagmus will not change direction, and it will get suppressed by fixation. So these are the clinching points in diagnosing BPPV nystagmus. I hope this video was useful, and thank you for watching.